We have a very exciting program this morning. I hope you'll find it just as stimulating as we did. And so without further ado, I'm going to launch straight into the first presentation. This one is going to be Medicare reimbursement trends 2012 to 2017 for femoral popliteal atherectomy and stenting. High reimbursement amount, possibly incentivizing inappropriate medical provider care, ? Presented by Dr. Matthew Hafner from SUNY for St. Barnabas Medical Center and SUNY Upstate, a combination of facilities.
Hello, my name is Dr. Matthew Hafner. I'm from Rutgers University, and I'll be presenting Medicare reimbursement trends from 2012 to 2017 for femoral and popliteal atherectomy and stenting. High reimbursement amounts, possibly incentivizing inappropriate medical provider care. So first off, I have no disclosures, and the source of my data was from the Center for Medicare and Medicaid Services database. So please note that all data moving forward is only for femoral and popliteal stenting and arthrectomy plus or minus angioplasty, not for all U.S. Medicare spending. So why look into this? Well, this procedure alone translated to almost $120 million in Medicare spending in 2017 alone. And with reimbursement rates in 2020 between $12,000 and $20,000 per procedure, it really made me ask, are there any trends in the data for this procedure that could help explain its increased rate of reimbursement? So if we look at this graph here, we can see that the annual Medicare reimbursement is broken up by specialties, is increasing steadily over the years. But are the proportion of reimbursements changing over time? As we can see from this graph, vascular surgeons in blue and cardiologists in red comprise the majority of Medicare reimbursement. Also note the relative increase in radiologist reimbursement in purple. So are the proportions of Medicare reimbursement similar to the proportions of providers performing this procedure? Let's see how the proportion of providers has changed over time. So in cursory analysis, the proportion of provider types seems to match with the proportion of Medicare reimbursement, but let's compare them side by side. So we have Medicare reimbursement on the left and provider type on the right. And as we can see, the cardiologists are accounting for a decreasing amount of Medicare spending and a decreasing amount of provider type. Well, the opposite is true for radiologists. In 2012, radiologists comprised 7% of providers and accounted for 7% of reimbursement. In 2017, radiologists accounted for 10% of providers and 15% of reimbursement. Cardiologists in 2012 were 45% of providers and only accounted for 42% of reimbursement, and decreased in 2017 to 37% of providers and only accounted for 29% of reimbursement. So are there relatively more radiologists performing this procedure? Are radiologists performing more procedures? Let's look at the amount of providers and total procedures to see if we can answer this question. So we have total providers on the left and total procedures on the right, and this is raw data. And as we can see from both graphs, the amount of each has more than doubled from 2012 to 2017. But will the rate of increase in providers or procedures explain the increase in Medicare spending? So these are graphs comparing the rate of increase in reimbursement versus the rate of increase in providers on the left and the rate of increase in procedures on the right. Rate of reimbursement increase is shown in both in blue. And as we can see, the rate of reimbursement is not simply explained by more providers performing the procedure or more procedures being performed. So let's look at all three together. As we can see from this graph, the rate of increase in total providers, which is in green, and the total procedures, which is in red, are closely related, and both show a slower rate of increase compared with the overall rate of reimbursement increase, which is shown in blue. However, we know from earlier that the proportion of provider types has changed over time. Could this possibly explain the increase in spending? Perhaps there's a relative increase in overall procedures performed by specialties with higher rates of reimbursement and a relative decrease in procedures performed with those with lower rates of reimbursement. So let's look at the proportion of providers compared with the relative proportion of procedures performed by each specialty. We have provider type on the left and procedures performed by specialty on the right. When we compare the two, we see that there's not a direct correlation between increased providers within a specialty and the amount of procedures that that specialty performs. So let's look at the average procedure per provider. First off, the national average, which is in red, and we'll see that the average radiologist, which is in green, is consistently performing more procedures than any other specialist. Also note that the average vascular surgeon in blue who performs this procedure tends to perform the procedure at approximately at or just below the national average rate. So are the reimbursement rates of individual specialists changing at different rates? And if so, could this help explain some of the aspects of overall increase in Medicare spending? So this is the increase in annual Medicare reimbursement rate. And as you can see, it's a relatively consistent increase over time. But let's look at the specialties. So the rate of increase in vascular surgery, which is in blue, reimbursement, closely follows the rate the increase in national average rate of increase, which is in red. Also note that the rate of increase of reimbursement for cardiologists, which is in green, is at a slower rate than the national average in red. And we can see the rate of reimbursement for radiologists in purple and general surgeons in black have increased at a much faster rate than the national average. However, rate of increase does not directly translate into increased reimbursement rate. So let's look at reimbursement rate by specialty. So first off, the national average per procedure reimbursement is in blue and highlighted. If we look at the specialties that are surpassing or very close to the national average, they include vascular surgery in red, radiology in light blue, and general surgery in purple. Are there differences between the amount of interventions per patient between specialties? Is this high reimbursement rate possibly incentivizing providers to perform more interventions on patients? Well, let's take a look. So this is the average number of procedures per patient by specialty. And we can see with vascular surgeons in blue, they have a relatively constant procedure rate per patient, whereas the other specialties tend to have more variable and a higher overall procedure rate per patient. Also note that the average cardiologist, which is in green, are consistently performing more procedures on the average patient than each year prior. With reimbursement rates in excess of $8,000 per procedure, the temptation to overbill or overperform procedures with a monetary motivation may come into play. So let's see if we can infer some aspects that are possibly taking place. So I chose a dividing line of 1.5 procedures per patient, as this would translate to 3 interventions on 2 patients. And the number represents the annual average. Being as this intervention can only be performed 2 times on 1 patient at a time, it seems a decent starting point to look for discrepancies within the data. So let's see what the data revealed. So first off, the spike in 2014 is most likely an anomaly, as general surgeons accounted for a small number of providers, and this rate was a one-time occurrence. So first off, some years do not have specialists with interventions per patient greater than 1.5. For example, 2012 had no radiologist with an intervention rate greater than 1.5. Also note that vascular surgeons, who are arguably the specialty that would or should be called upon for more challenging cases that have a higher likelihood of multiple interventions, have a much lower percentage of providers with intervention rates greater than or equal to 1.5 when compared with the national average, radiologists, and general surgeons. So while vascular surgeons are performing less than the national average of interventions per patient, they still account for an increasing amount of total procedures. So here are the take-home points. Radiologists and general surgeons are being reimbursed at higher rates than vascular surgeons. Radiologists as a whole are performing more procedures per provider. Cardiologists are performing more interventions per patient than other specialties. And vascular surgeons' rate of reimbursement is increasing at approximately the same rate as the national average. Vascular surgeons also perform less than the national average procedures per patient.
Dr. Hafner, we have you here for some questions, and while we wait for questions to post in the chat board, I'd like to get started with a couple. And I think the topic is very relevant, politically, tricky to navigate for sure. I think the first question is: was the database granular enough for you to indicate to kind of dive into what kind of indications were for the treatments? Was this claudication, rest pain, critical ischemia? That most of the atherectomies are being performed for.
Can you hear me? Just want to make sure.
Yes.
Okay, so unfortunately, the data set did not have indications or procedure included with the data, so that was unable to be fleshed out further.
Okay, we have a question from the audience. So the question is this a Part A claims only? Many procedures are done as an outpatient, so Part B money. And if so, how does this impact your findings, since patients undergoing inpatient procedures will differ from outpatient procedures?
Yeah, so this included both outpatient and inpatient, and the data was analyzed as a conglomerate to get a better idea of overall national trends. There is significant reimbursement differences between inpatient and outpatient performed procedures. And due to the
intervention indications, we were unable to elucidate and further delve into those aspects in the data.
Okay. I mean, as a follow-up comment, I think that's very important because I think outpatient reimbursement was a huge driver for the atherectomy boom. And my additional question then would be, did you look at the changes in reimbursement over year to year so that you can see if you can identify whether it was change in reimbursement that drove certain upticks, or was it just a lag in terms of figuring out that the reimbursement was high enough that the providers started being encouraged to use the atherectomy more?
Yeah, in the presentation, I actually broke up the rates of increase in reimbursement and total provider, and it looks like what I found was the increase in providers increased before the increase in procedures, and then only after both of those increased did we see a significant increase in the overall rate. So it looks like providers were the first to increase, but that's sort of what the data revealed, that providers first, then procedures, and after both of those increased, we saw an uptick in overall data.
Okay, one last question from Sean Roddy. These lower extremity endovascular codes get new CPT codes in 2 to 3 years, and they are revalued in the office. It looks like they may be cut in the OBL near 50%. So do you think that will decrease all procedures, just the outpatient procedures? And how about the specialists performing these procedures?
Well, I do think that the neutrality law and the outpatient reimbursement will have an impact on the data. I think that the amount of procedures performed will most likely decrease in the outpatient setting, but I think that there's overall still a steady number of patients out there that need this procedure, so that I don't anticipate a significant decrease in overall procedure intervention, but I do feel that the net neutrality, or not net neutrality, the Medicare neutrality law will have an impact in overall spending in this realm.
Okay, we're out of time. We got to move on to the next one. Excellent presentation. Thank you so much.